The Pittsburgh Regional Initiative was founded in 1997 by myself and Paul O'Neill, at that point the chairman and CEO of Alcoa, eventually Secretary of the Treasury. And it's important to think that we were an initiative of the business group. And also the year was 1997. There hadn't been an Institute of Medicine report on to err is human or crossing the quality chasm. So we were the Jeremiahs telling them that the healthcare system in their country, speaking to the CEOs of our large corporations, the healthcare system in their country was seriously flawed, and that dramatic quality improvement, particularly at the front line of care, was actually their best cost containment strategy. So revolutions come from a truth. So if we're talking to the business community, this was our truth. 40%, 40 cents of every dollar they spend on healthcare buys no value. It buys waste, preventable complications, unnecessary treatments, et cetera. And that if they support the initiative, we will be working to deliver 100% value. This has been our early truth. It's our medium truth, our late truth. We've really stuck by this. This is kind of our message. One thing when you work with Paul, it's always a delight, and Alcoa being not only the safest corporation in the world, also at that point one of the highest performing, put us all through Alcoa University to learn Toyota lean production thinking and what does a high-performing organization that doesn't deliver 40% waste look like. And then we went out on the floor in hospitals. I had only been in hospitals for 3 simple pregnancies. We got to see the chaos and the random behaviors and everything that is counter to everything that Lean and Toyota stand for. So we were off. This mess that you look at, this mess was our first meeting. We were extremely nervous talking to a lot of healthcare professionals, providers, that we were bringing Lean to healthcare. We showed this slide. This is all the workarounds. You're looking at 768 additional steps because one Ecotrin wasn't delivered on time in one hospital, and the nurses in the room jumped up and said, "That's my life." So it was very satisfying. We were off. We do look at the lack of education in these methods, in basic performance quality improvement methods. It is our cycle of despair. The fact that our health professionals get no grounding in this is very much a core thinking of everything we do at the foundation, and there has been so much movement in the last year. We're very excited, but we bring these methods to health professionals, particularly at the front line in a continuing education space, because it's not part of their education. It did occur to us early on, particularly when they threw me off the state hospital board. The Hospital Association said that Paul and I were the most dangerous things in healthcare because we were raising expectations. And it makes me so happy. I never leave it out of a talk. Those who know Carolyn Scanlon, she keeps saying, "Karen, when are you going to get over it?" And I say, absolutely never. Wherever I go around the world, I do mention the Tiffany bowl you gave me when you threw me off the board. But I love revolutions. I wanted to be Emma Goldman growing up. I couldn't be happier. So we started to be very systematic about what does a revolution need? What does the quality movement, which I think is a revolution, need? And it started out just defining a vision, having an intervention, having a solution, demonstrating the value of that, aligning incentives, thank you, Obamacare, and spreading and stabilizing change. And that's what we've been doing. So I mentioned that we bring a lot of training to the front line. We love the champion programs. We're not a high-powered, expensive consulting firm. We don't want to be. I want to train people who are the change agents on the floor in their organization. So every year we have a different champion program. We also have fellowships that go on every year working with graduate students because they're not habituated. It's so wonderful to train. Right now we're working on long-term care champions. This is the best part. We get to train across the country. I get to speak in foreign countries, and Harold doesn't edit my slides. So when I'm in Canada, the United Kingdom, or Korea, or in Jerusalem, I'm on my own. It's really happiness.
There's that trap door over here.
Harold wanted me to go back. We love it. It is ancient history, but it did get us on the map. If we'd failed at this, I wouldn't be speaking here. Many of us might not be. And that is, if you know Paul, he's very ambitious. We announced that we were going to eliminate central line infection in 30 hospitals in Western Pennsylvania, partnering with the CDC. Everyone said it can't be done. They're an unnecessary, unpleasant byproduct of healthcare, and we couldn't do this. And this is legendary. We were very fortunate. We had a 68% reduction in 4 years, and we were off. As Harold does want me to also acknowledge, which is terrific, we did find units that eliminated central line infection, and they sustained it over the years. So this blew away all the arguments that these methods don't work in healthcare, and also that this kind of dramatic improvement is impossible. So this was defining for us. Happily, we moved on to the VA just because at those days, it was so easy to work at the VA. And they said, well, you can do central line, but you can't do MRSA. I couldn't even pronounce the real name of MRSA at the time. They said, you can't do MRSA. Big deal. You did central line. And so the VA was our partner, and they threw themselves into the work. There's a lot of creative things that happened. Harold won't give me time to tell you, but this really was a lot of fun. And the good news is we had a dramatic reduction. The best news is that the VA took it nationally. They took it across their whole system, and they were able to sustain it. And for me, the big excitement, we're the first chapter in Atul Gawande's book, Better. We have many stories of success, none of which Harold will let me tell you, but the good news is Neda Grundon wrote a book about us called The Pittsburgh Way. It did get translated by the publisher in Korean, which is why I got to go to Korea this year, which has been very exciting. But anyway, we stayed in the beginning mostly in hospitals, and we did what I call spot remover, problem solving with lean, using lean to fix something that was broken. And it was a good beginning for us because we had to prove, as I told you, it's a revolution. We had to prove that these methods work. So we did spend a fair amount of time doing very interesting things. Last year, just before I went to Korea, this was really convenient in Japan, we won the Shingo Prize for the work that we've done in lean. So the good news is at least we're doing something in healthcare that's acceptable. As you can see, we're not too proud of it. The one thing that's good is our methods attracted a lot of attention. You will see Harold and I there, our beautiful faces. I had a different hair color on the cover of Modern Healthcare. By the way, they would not let us smile, which is why we look so glum. And it was a minor paper where Harold actually did the math. We showed that hospitals made money on infection. We expected a storm, right? We thought everybody would be furious. So we met with the CFOs from the hospitals. They said, we knew that. So it was lively. We've had a wonderful run, and we enjoyed our early successes. One thing that a lot of people challenged us on, they said, you're making extra work for harried health professionals. But I want to make this argument. We did not. We took on high turnover rates in a liver transplant unit among nurses. It was costing the hospital $800,000 a year. We brought it down to zero. And the point I want to make is these methods make less work. They create less hassle and less chaos. The things that we do are not adding to the burden of people at the front line. We had to move on. We had to move on. I love working in hospitals. One of you, I won't name you, sent me a letter and said, you know, you guys are cute so far, but until you get out of the hospital, you're not interesting. So I think that there's some truth in what they were saying, this kind of spot removal, dealing with problems in hospitals. We had to move on with lean and see if we could work on some of the issues that are really driving the high cost of care in our country, and that is the care of patients, particularly those who are frequently hospitalized. A truth that really guides us and that has defined our work is that 1 in 5 patients return to the hospital within 30 days. We mined our own data in Pennsylvania. We have an excellent mandated reporting system. And we were shocked. The hospitals were shocked. Everybody was shocked when our researchers announced this. But we've also found that this is true across the country. So one of the things we do, we have a research team, and we spend a lot of time early on saying, who are those patients? Who's going in and out of hospitals? We thought people knew, but they didn't. So you'll see in our agenda just about everything that our researchers uncovered. Behavioral health and substance use, a real complicator for people who have other chronic conditions, but don't go in and out of hospitals. HIV/AIDS, they are not going in and out for conditions related to HIV/AIDS specifically. They're going in and out for the same chronic conditions others with the same severity are, but they're going in and out for a variety of issues, lifestyle and others. End of life, huge. A lot of people are going in and out of the hospital. They don't want to go in and out of the hospital, but as you know, we have a lot of challenges getting people on hospice when they should. And a lot of people go in and out of hospitals from skilled nursing. We were actually shocked at the numbers. So one thing I just mentioned, a lot of people are readmitted from skilled nursing. Actually, the highest rate of readmissions comes from skilled nursing. So we took our methods to skilled nursing, and this was challenging. I mean, it's an interesting, different population we have to do, and we enjoyed a lot of work with CNAs. So we had a nursing home willing to go forward with lean and did some very exciting things. One thing they did is reduce hospitalizations down to 0 for those that weren't scheduled for solid reasons. They've also done a dramatic job, 60% reduction in pressure ulcers, 55% reduction in UTIs. So it works in nursing homes. It's pretty exciting. We just got, in partnership with others, a wonderful grant from CMMI. If anyone's here, we thank you. $19 million to keep continuing this work and work with 16 skilled nursing facilities, so we're pretty excited. So someone once said, if you only had one slide, Harold would have loved it. If you only had one slide, what would the slide be? And this is our systems vision defining all our work right now. We're looking across care settings. So what are the essential services and what are system requirements? So essential services in our mind, care management, clinical pharmacy, we love clinical pharmacy, patient engagement, we're not very good at that in our community, and behavioral health screenings and treatment with our wonderful partnership with ICSI, which has been defining and satisfying in every way. System requirements, health IT, quality improvement training. This doesn't happen spontaneously. It will not happen unless people get some basic grounding. And payment incentives, performance incentives, mostly when we started they were lacking. Things are looking better. That defines it. Much of the things we talked about that were essential requirements, as you know, aren't reimbursed. So we spend a lot of our time trying to show through quite a few demonstrations that if you put these things in, they do produce a return on investment. They will give you lower cost and higher quality. So that's how we spend our time. Harold definitely will not let me talk to you about all the things we're doing right now, but it is a very exciting time, and he's right about that. The one thing I say, my kids, others say, what do you do? And I say, I keep people out of hospitals. But I really mean it. Most of these different initiatives, and they're all separate initiatives with different teams, almost every one of them is keeping people who don't need to be in hospitals out of hospitals. And we do work with end of life. We do a lot of things that, for us, are very satisfying. But the key theme through all of them is don't go to the hospital if you don't have to. Harold did a phenomenal, and this was very defining. We were moving out of the hospital, we're moving into chronic disease, and Harold led an initiative in our community on reducing readmissions for COPD, chronic obstructive pulmonary disease. And it was very defining because do these lean methods work? Can we actually take Kaizens and other traditional interventions and apply them outside of a hospital unit? And we took on COPD. I won't get to tell you all. We always joke, we call it the inhaler stupid initiative. But the one thing that was amazingly defining is how Harold was able to get staff, respiratory therapists within the hospital, and our nurse home visitors to make sure that everybody knew how to use their 1, 2, or 3 inhalers properly. There are many other things that the nurse care managers did and that they did in the hospital, other interventions, but I think this is the most defining, and you'll tell me if it's not. Dramatic. Within a year, I think it was actually less than a year, there was a 44% reduction in admissions and readmissions. This was pretty exciting, and we did get to speak to lots of interesting places because of this, but it also said these methods work, then you don't have to stay within a hospital. I won't mention these. Sonny did the best job ever, but it's been a wonderful partnership across regional collaboratives, working with SANI, working with Wisconsin, a real leader in substance use screening, to bring these initiatives to our community. We decided to take on HIV/AIDS. I also run a foundation. We are the fiscal agent for state AIDS funds. We did a lot of the same things that Harold did with COPD, working with the agencies that serve people with HIV, 52.3% reduction in readmissions. It's been wonderful for my team. They get to speak all over, and they just love it. So, you know, these things are very doable and very exciting in short time. I mean, these aren't things where you have to wait 4 years. We got a nice initiative a nice grant from our state. We are going to be training HIV workers across Pennsylvania to replicate the work that we did, particularly reaching out to people that are called lost to care. This has been enormously exciting for us. Can we tie a lot of what we do together and come up with a new model of care? CMMI graciously gave us a very nice grant. We have 7 regional hospitals who have developed a whole new model of care. We call it secondary care. One thing that concerns us is the unintended consequences of what we think is the good work we've done over 15 years. And that is, if you look at what's happening with the Affordable Care Act and the work we do, I told you I keep people out of hospitals. I didn't intend to kill the community hospital. That was like not our intent. So this really troubles us. So if they're not going to be using units because they don't need to fill so many beds, what do they do? Most of these community hospitals in our state deal with docs in 1- and 2-person practices. That is by far the majority of them. So we have created within the hospital, in an empty unit, we took the first hospital, it's been wildly successful, and put in all the services that you might get in a large multi-specialty practice if you're lucky, or an FQHC, but you don't get in a 1- or 2-doctor practice. We've put them in the hospital using the team the hospital already had. They helped us rebuild the unit. It wasn't really expensive. And now there's a kind of secondary care partnership between the primary care docs and the hospital for the chronic patients. So it works at discharge, it follows them home, and it supports their care in the community, and does the thing that the docs can't do really in a small practice. So we're very excited. That's going to 7 hospitals. We thank Robert Wood Johnson. They are helping us work with our largest insurer and others to measure the cost savings and to look at payment reform. This is our sustainability strategy. If this model works, we're very excited, and we thank URWJ. One thing we've learned through our training, it's face-to-face. It's face-to-face. Well, you know, you all followed what happened in the Arab Spring. Technology is a huge game changer, and one thing we know, and Rand did a study of us, and we loved it, and it was flattering, but the conclusion is you have to train a lot of people, and you have to give them more training if you want to see a big impact. So we've moved into technology, taking a lot of what we do and developing a tool to help organizations apply first of all, have large numbers of staff learn the basic quality improvement method techniques, to record them online. This is really important. Most lean is done by hand on something called an A3. We had to have it recorded online so people could get rewarded and share. They could share what they did, and they could get rewarded by their organizations. Form communities of interest if we're working on COPD readmission reduction. And also someone start collecting a portfolio. Look at all the quality improvement initiatives I did this year. Will someone pay attention when it's time for my performance review? So, yeah, I mean, there's not much reward, don't forget. And until we move into new payment models, hospitals lose money on a lot of the quality improvement work we do. So, and staff don't get rewarded. It's outside their ordinary boundaries. We've got to have a way to reward this. I call this the Todd Park Initiative. We are also as charmed by Todd. But anyway, there is no doubt in our mind that a lot of the quality improvement work we do needs to meet information technology and large data, and that there are going to be a lot of breakthroughs. So we took casino money, it was available, and we built a state-of-the-art, they gave it to us, state-of-the-art training center, which has been very exciting. So what makes us unique? What are we most proud of? I think, first of all, bringing awareness to the flaws in the health delivery system. We were the early Jeremiahs. We had Lucian Leaps data. We had very little else to go on. Thank God all the studies have followed. We brought lean quality improvement methods. To be specific, Paul O'Neill did. He took them from Alcoa and brought them into the hospital. We were able to prove its value over and over. The good news is it always works. Take any infection, particularly ventriculostomy, UTI, any of the infections, and we'll do a great job. It works, but it works in all settings, and that was important for us to go to skilled nursing primary care. We extended our early successes to starting to look at overall system redesign. Whoever sent me that letter, we couldn't stay doing little, spot removal in hospitals. We attracted, thank goodness, a lot of grant money over the years to keep testing the efficacy of lean and spreading it. And now we're kind of excited about trying to move to this new frontier. We did just start a new fellowship called QIT, where quality improvement meets information technology. And I didn't know how many graduate students would come. We had an enormous response. We're very excited. We couldn't take a lot of the people who applied. So there's a generation out there who's really excited about this.